Japan, especially our hospital, Shizuoka Cancer Center, and we have pre-operative and post-operative case conferences in every week. And then in pre-operative conferences, and we discuss this patient is needed any treatments, surgery or endoscopic surgery, endoscopic resections or chemoradiations. And so I will present the only one cases from the Shizuoka Cancer Center cases. And at first, I present endoscopic pictures. And so any endoscopic doctors analysis these cases. Okay? And case in the 67 years old male patient. And this is endoscopic pictures, including the dye spreading endoscopic pictures. Okay? And some endoscopies. Okay? Nobody endoscopies? Nobody?
Any problems? No problems.
No problem. And so, and in the endoscope, I'm not endoscopist, I'm pathologist. And I analyze these cases, endoscopic features. And this is the region, we can see regions here. And this is, this portion is fungus. And in this film pictures, we can see irregular, nodular, elevated regions. And marginal fold convergence to these hairs. And this area is, we can see some a little depressed regions. And this region is composed with elevated region, nodular region, and depressed regions. And in this more close-up view of the conventional white right endoscopic features. And here is there. And fibroscope, and this region located in the EGJ, near the EGJs. And this is a nodular elevated region with a little bit depressed regions. And the margin of these tumors is more elevations. And so, from these pictures, Japanese endoscopists make a diagnosis in the to C plus to A region with marginal elevations. And these features suspect the more submucosal invasions. And this is spreading, Rugol iodine staining in the endoscopies. And this region is located is lower esophagus. And this is unstained area near the unstained area could be found in the EGJ of the esophagus. And so this is suspected is the existence of the Barrett esophagus. And this region is a more close-up view, is almost same as finding is the previously pictures. And so, endoscopic diagnosis is EGJ cancer, GBL type 2. Location is mainly abdominal esophagus near the EGJ and extend to the cardiac regions, gastric cardiac regions. And growth type is 0, 1+ to C, and the size of tumor about 15 millimeters. And clinically, this patient show short segment Barrett esophagus. And depth of invasion, CT1B SM. And so, endoscopists and surgeons suppose surgical resections. And surgery in the lower esophagectomy and proximal gastrectomy with esophagogastric road anastomosis was done. And operative diagnosis, surgical diagnosis is Barrett adenocarcinoma is type 1, and surgically T2, N0, M0. Surgical stage is 2A, and this patient have been follow-up. Is no recurrence and distant metastasis, well conditioned after 7 years. And the pathological findings. In the first one is a gross, microscopic features, and from the gastric wall, from gastric fold convergence to this point. These pictures correspond to the endoscopic features, and this is the SC junctions, and this is the redness mucosal layers, and so this tumor probably extend to the esophageal squamous beneath the squamous epitheliums. Probably esophageal mucosal layer or submucosal layers. And however, in the surgical margin is negative from the gross features. And this is a real-world staining of the in the fresh materials. And this is black iodine staining area at the squamous epithelial regions, and these iodine staining area is extend to the columnar epithelial regions. And this is the end of the fold. This is the end of the fold. This is the end of the fold, and this line is an EGJ from western side also. And this is a columnar epithelium, and so we make a diagnosis of Barrett cancers. And this Barrett cancer, Barrett epithelium, is over the about 1.5 millimeters, or under the 2 centimeters. 1.7 to 2 centimeters. And so we make a diagnosis with a short Barrett esophagus and cancers. And this is a hormone fixed specimens, and almost same pictures as same as fresh materials. And the result of the histological examination, this white dot line is the EGJ, and cancer is located here in Barrett esophagus, in the Barrett esophagus. And this is a short segment Barrett esophagus. And here is the columnar epitheliums without intestinal metaplasias. And X mark is the existence of the esophageal duct or esophageal gland. And histologically, the background of the mucosa is show Barrett esophagus. Why? And squamous epithelium island exists in the columnar epitheliums. Okay? And this squamous island, existence of the squamous island in columnar epitheliums is one of the decision of the Barrett esophagus histologically. And this Barrett esophagus here, low power view. This is the squamous epithelium. And the other portion, and we can see is the esophageal gland or duct and gland could be found in the submucosal layers. Also, this finding beneath the columnar epithelium is a decision of the criteria of the diagnosing of Barrett esophagus histologically. And the other portion, this is a cancer here. This cancer is a well-differentiated adenocarcinoma, invasion into the submucosal layer, and this is a Barrett's fungus, and this is a cancer. And however, this cancer covered with very thin squamous epitheliums. And here is the Barrett's fungus. Why? In this area, we can see double musculus layers. And so, this double musculus mucosal layers is one of the decision of the Barrett's fungus diagnosis, histologically. And in the Barrett's fungus, we cannot detect the intestinal metaplasia. And this Barrett's fungus is a cardiac gland type mucosa. And this is a cancer in the invasion into the submucosal layer, and however, covered with the squamous epithelium, very thin squamous epithelium. And grossly, we can detect the elevated region in the squamous epithelial regions. And from the macroscopic features, we suppose this cancer is invasion into the submucosal layers. And this protrusive region is correspond to the this histological features. And histological type is a well-differentiated adenocarcinoma. And finally, this cancer is adenocarcinoma with short segment Barrett's fungus, Barrett adenocarcinomas. And however, this patient show lymph node metastasis. Only one lymph node metastasis. Number 110 lymph nodes. Yeah. This is a very minute lymph node metastasis. And finally, superficial esophageal cancer with Barrett adenocarcinoma. And histological type, well-differentiated adenocarcinoma, high-grade TBR, type 1 or 2A plus 2C. The size of tumor is 28 millimeter in maximal diameter. This size is different from the endoscopical pictures. And depth of the invasion, SM3, and LY0, lymphatic permeation or venous permeation, 0, and lymph node metastasis, N1, N plus, and 1 and 18. And this, and the other intraoperative diagnosis of the lymph node metastasis, 1 pieces. And finally, endoscopic pictures. Endoscopic pictures here, and resected material, and result of the histological examination is completely same. And here, in the a little bit polypoid region, show some mucosal invasive areas. And I talk the definition of the esophageal junction in the world or in Japan. And this problem is a very controversy in the world. And in the Western countries, the EGJ junction, EGJ, is correspond to the end of the lower sphincter muscles. However, we cannot detect these regions. And so, in the terminal end of the gastric fold, and interior from cystic stomach to the esophageal canals. And fourth, endoscopically, in the terminal portion of palisading vessels in the lower esophagus. And palisading vessel is distribution in the lower esophagus here. And these palisading vessel is ended in the EG junctions. And so, and endoscopically, this is the palisading vessel. And the end of the palisading vessel here. And here is the Barrett's force. And this is same cases. And this is the end of the gastric fold. Here is the Barrett's force here. And here is the Barrett's force. It's completely same. And this is a palisading vessels in histologies. And the palisading histology is a little bit long diameters. And macroscopically, this is almost normal EGJ. Is a squamous columnar junction is almost same EGJ. And this is a Barrett's force. And SC junction is very irregular, running, and rise up to the esophagus. And this is the Barrett's force. And histologically, histological definition of the Barrett's force is esophageal gland or duct beneath the columnar epithelium. This is a columnar epithelium, and this is a esophageal gland. And squamous island in columnar epitheliums. And double muscular layers. And this definition is easy to make a diagnosis of the esophageal Barrett's force in resected specimen, surgical and endoscopical resections. And however, biopsy specimen taken from here, and this only histological features of the mucosal layer, we cannot make a diagnosis of the Barrett's force in histology. And so, and it is very important, we know where is the biopsy taken from esophagus. And if the endoscopic diagnosis is Barrett's force and biopsy specimen taken from here, and we make a diagnosis of Barrett's force without these features. And in Japan, in Asian countries, and almost variety is false. It's short segment. However, in Western countries, is almost case is long segment variety is false. And definition of the short segment variety is false is is first one replaced with columnar epithelium on circular or partially lower esophagus within 3 centimeters in length. This is the almost same European and Japanese guidelines. And esophageal duct or gland beneath the columnar epitheliums, double layers of the musculus mucosa and squamous island in columnar epithelium. And it is necessary. It is not necessary. Specialized columnar epithelium, intestinal metaplasia or gallbladder metaplasia is not necessary. However, in USA, in the USA, this is only valid as far as definitions. Thank you.
Thank you very much, Dr. Shimoda. And we have some questions from the audience and colleague. Please provide, Doctor.
You're welcome, Sergey, with your question. Dr. Shimoda, thank you for your very interesting demonstration. Thank you very much for your very interesting and informative presentation. I have 2 questions. One is about the demonstration itself. The second question is about approaches to diagnostics of early gastric carcinoma. You demonstrated, you have a case when it was not very clear from the presentation, was it a primary diagnosed patient or she had been treated and followed up with Barrett esophagus. It's very important for assessment of this clinical situation. And the second question, immediately after endoscopic study, what about biopsy? They were not taken. It was decided about operation, about surgery immediately. And it was resection of this segment of the esophagus, gastric segment. How often you carry out such major operations without previously taken biopsy that could specify the diagnosis?
And the first question is, as I spoke, and when we make a diagnosis with a biopsy specimen, it is very important we take clinical diagnosis and clinical features, especially in the endoscopic pictures. And so it is very important to correlate with endoscopists. And if in Japan, if the diagnosis of the biopsy specimen is different from the endoscopic features, endoscopist running here, my room, and we have a lot of the discussion for patient. Okay?
Спасибо. Но в данном случае
Thank you, but there was no biopsy. There was no biopsy in this demonstration, in this case. You mentioned that You didn't mention any biopsy, so as far as I understood, the surgery was done, this big surgery, without any biopsy.
Endoscopists make a diagnosis of more invasive cancers, and so in the surgeons.
Да. Да, очень хорошо. И второй вопрос.
And my second question is it's about your view, your opinion, and by approach. There are two terms, two notions. The first term, it's adenocarcinoma, gastric adenocarcinoma in situ. So in WHO classification, this term does not exist. They do not use it. And second, your attitude to the one form of in situ gastric cancer that is connected with this spindle, pardon me, spindle type of cancer. Singlet, pardon me, singlet type of cancer.
Book, we describe the same condition between the high-grade dysplasia and intramucosal carcinoma in Japan. Okay? And so, if the Western countries and the pathologists make a diagnosis, when pathologists make a diagnosis with a high-grade dysplasia or intraepithelial neoplasia with high grade, is necessary for any treatment. And the intramucosal carcinoma, non-invasive intramucosal carcinoma and high-grade dysplasia is same condition. Why? The high-grade dysplasia, naming of the high-grade dysplasia without the definite invasions.
И все-таки
Do you use in your work such term as cancer in situ when it's about adenocarcinoma of gastric carcinomas, not intermucosal, but in situ carcinoma, not mucosal?
In Japan, we use only intramucosal carcinoma with and we don't use the carcinoma in situ.